Okay. So let's start talking about absolute incomes. I think most of us here today would agree on that our absolute living standards to some extent relates to the way we feel. So there's possibly, I think most of us would agree on that there's some kind of relationship between absolute incomes and health. So just as an illustration, I think it's very nice to have some historical perspective on this. Here we're using the work by Madison on global GDP per capita levels over a very long time horizon. So looking into the red bars, they show GDP per capita in the world as a whole over the time period year 1000 until the very beginning of the millennium. So looking at the red bars, we see that for quite some time in history, GDP per capita in the world was quite low, but around the time of the industrialization, we can see that these red bars start to grow quite significantly. At the same time, we've seen a tremendous development in health in the world, on average. So the blue line corresponds to life expectancy at birth over the same time period. Similar to the development in GDP per capita, it was quite low for quite some time, and there was a dramatic increase in life expectancy at birth in the middle of the 19th century and onwards. So a child that is born in the world today will on average live 5 years longer as compared to a child that was born 50 years ago. And in Sweden, actually, a child that is born today will actually on average live 3 hours longer than a child that was born yesterday. It's quite fantastic, isn't it? So, it's very difficult to say, is it health that generates good incomes or good incomes that generates good health? But still, I think we can say that there's something into this relationship. So instead of having this longitudinal perspective, let's go for a snapshot of the world. This is from the year 2000. The graph will look very similar today if we would make it for 2018 with respect to the shape of the curvature of the relationship, at least. So what we have here on the x-axis is once again GDP per capita. On the y-axis, we have life expectancy at birth. Every dot represents a country, and the size of the dot represents the population in that country. So once again, we see that there seems to be something into this statement that I said that, okay, there's some kind of relationship between incomes and health. If we believe it runs from incomes to health, then it seems to be positive, but it's not linear, it's actually concave. Meaning that if a country like the US would increase their GDP per capita by, let's say, $1,000, that increase would not improve health as much as if those $1,000 came into the GDP per capita of Bangladesh. This graph is also illustrative in the sense that we see that there's a couple of outliers. Namibia, South Africa, Gabon, they all seen a reducing life expectancy over the past years due to the HIV/AIDS crisis, pandemic. And also, we note by this graph that there's huge variation across countries in the world. So there's regional disparities that we don't capture if you look into the global average. But the interesting thing is, if I would go into the country level, so within Sweden, within Stockholm, within a municipality, we would see the same kind of curvature of the curve if we would line up in income and health. It's positive, but it's concave, it's non-linear. And this is important to remember. Coming back to what Therese talked about this morning, so there is a health gradient within countries. And actually, so coming to the topic of my talk, inequality and health, some researchers brought to the table the hypothesis that the reason that there's differences in this gradient across countries relates to the inequality level within countries. So here we have bars on Sweden in yellow, United Kingdom in blue. On the x-axis, we have income quartiles. the higher the richer. I mean, the larger the richer. And on the y-axis, we see mortality risk. So this is exactly what Therese talked about, that there's a social gradient in health, but it seems to differ across countries. Here I use income as my variable. Therese talked about education, and it looks a bit different. But I mean, what was brought to the table by researchers about 20 years ago was that the reason why we see differences in the gradient across countries relate to inequality. Especially, this was brought forward by Richard Wilkinson, who has produced several books on the topic. Some of you might have read The Spirit Level, that came out in 2010, in Swedish, Jämlikhetsandan. And he has written a couple of books on the similar topic. This one, this graph comes from The Spirit Level, written by Richard Wilkinson and Kate Pickett in 2010. So what they note in this book and in their research is that there seems to be this kind of relationship between income inequality and health on the aggregate level. So what we have is income inequality going from low to high on the x-axis, on the y-axis, life expectancy in years. So that a country like the US, having a high inequality, well, they have lower life expectancy at birth as compared to Sweden, for example. So Richard Wilkinson was the first to bring to the table that this relationship is causal. He said there's an income inequality hypothesis, so it's causal, and it's also the case that inequality has a negative effect on everyone's health. So in society, everyone will be negatively affected by large differences in the income distribution. And of course, this is suggestive and very politically controversial, and this hypothesis has brought quite a lot of media attention and also quite a lot of political attention. Coming back to what Jesper talked about, this is the graph showing Denmark, Finland, Norway, and Sweden, and the development in income inequality from 1990 to 2016. On the y-axis, we have Gini for disposable incomes. And as you all remember, if we would have taken an even longer perspective, it would have looked a bit different, because and I should definitely say that in 1990, we started from very low levels of income inequality in the Nordic countries. But what we see is that there's been increasing inequality. The patterns are a bit different across the Nordic countries, but remember from Jesper's talk, there's been increasing top incomes, small or no increases in poverty, since most part of the distribution seem to have had income growth. And of course, if this is so seeing this development and going back to the hypothesis on income inequality and health, well, if inequality is a health risk, this development is of course a challenge. So I think it's important to then, if this is the case, why is it the case? What are the potential mediators, the mechanisms? What is it in income inequality that actually transfers to poor health? Well, one suggestion that has been discussed in the literature is that we are comparing ourselves with others. So this Swedish tabloid states regularly these kind of comparisons, or like that you can see how much money does other people in your local community earn. It's not a pure Swedish phenomena. This is from Ilta Sanomat, and here you have a list of those who earned more than 100,000 euros in Finland in the year 2017. I don't think anyone in Luleå earned that much. This person, number 2 on the ranking, he's the founder of the game mobile development company Supercell. So he earns quite a lot. So, I mean, one hypothesis why inequality would transfer into poor health would be that we are social beings. We socially compare ourselves to others, and this could generate psychological stress, in turn resulting in poor mental and physical health. A second possible reason could be that in high inequality countries, we also have low trust. Inequality is then a signal on that some people act unreliably, and we also know that in high inequality context, people tend to participate less in social networks. This could also have inequality effects, health effects, because people who socialize less have on average worse health. And also, if we socialize with others, we also actually learn about what we should do to stay healthy. A third possible mechanism is crime and violence. So this relates to the work by Becker, who has a nice theoretical model showing that in high inequality contexts, actually crime will be higher because there are larger economic returns. In high inequality contexts, we have high mean income, so the expected return of crime is large, and there will also be large differences between mean income and low skilled wages. So, if there's a lot of crime going on in society, first of all, if I'm affected myself by crime, that can have a direct health effect, but also if I'm just worried about being being affected by crime, I worry about myself, I worry about my close friends and my family. Of course, that could also translate into poor health. And finally, a fourth mechanism why possibly income inequality could affect people's well-being and health, that relates to political outcomes. So in a context with high inequality, it's reasonable to think that those that have a lot of money also have a lot of power in political terms. And they could be driven by self-interest. And in a high inequality context, we could also have a conflict of interest between poor income individuals and high income individuals, which could then affect access to public goods such as healthcare. So that could also have an impact on the average health or health in the society. So what does the evidence tell us? Well, let me first talk about the largest chunk of the existing literature out there on the relationship between income inequality and health. And that is studies that use population health measures. They use aggregate data, so average levels of health. There's more than 150 published articles in peer-reviewed journals. I would say that a clear majority of these suggest that there's a relationship between income inequality and health along the lines that was stated by the income inequality hypothesis. So income inequality will make us sick. They use many different health outcome measures, but particularly they focus on objective measures, so mortality risk, life expectancy, cancer cases. And they all use aggregate data, as I said. It's population level. So it's data for countries, regions, municipalities, and so forth. And there's a very limited discussion about methodological challenges in this literature. And I will bring up some of the things that I think is necessary to think about when we read these articles. So first of all, omitted variables. Here we have a graph showing the Gini coefficient on the x-axis, and on the y-axis we have the number of new cancer cases per 100,000 inhabitants in Sweden, and this is in Swedish counties in the year 2008. Okay, so we see this kind of positive relationship that higher counties with higher inequality also have more new cancer cases. But I think it's important to remember that this kind of scatter plot doesn't really say anything about causality. And especially it's important to remember that there could be a third factor actually affecting both Gini coefficient, so inequality, and the number of new cancer cases. In this case, I think the variable that I would mostly, or like first of all think about would be the age distribution. We know that the income distribution seems to vary with demographics, and we also know that the number of cancer cases relates to how old the population is in a county. A second thing related to causality, well, that is reverse causality. Couldn't it be that health affects inequality rather than inequality affects health? That could run through labor market effects, so that if we're healthier, we're more productive, we get promoted more often, we are less discriminated. It could also run through education effects, because we know that children that are more healthy, they tend to perform better in school, and that translates in the end to a better labor market outcome. I think the most important thing to think about when we see these aggregate studies is that actually we need individual level data rather than using population health measures. And 10 to 12 Thursday morning, I will give you a small theoretical model. It's a theoretical model where we have 3 individuals, Anna, Bertil, and Cecilia, in a hypothetical society. In the first case, Anna earns 18,000 Swedish crowns per month, Bertil 20,000, and Cecilia 22,000. The next year, there's a regressive transfer. So actually, Anna, who's the poorest, she has to give some of her money to Cecilia, who's the richest. Okay? So 8,000 kronas per month runs from Anna to Cecilia. What happens in this society? Well, first of all, we see that the average income level remains the same between year 1 and year 2. We also see that the income distribution becomes more dispersed, so income inequality increases. But what has happened to health? Well, that's a more difficult task, actually. But thinking about that concave relationship I showed you on the Preston curve, it's reasonable to think that Anna, who lost money, or doesn't have that much money anymore, her health has it has decreased, while Cecilia's health improved. But that Anna's health loss was larger than Cecilia's health gain. This stems from, this comes from the absolute income. This relates to that they have different absolute incomes as compared to the first year. So, but if you think on the population level, this actually generates a situation where income inequality correlates with negative health outcomes. So actually, when we look on the population level, this masks a lot of things. We don't know whether it's actually income inequality that matters for health or that generates this situation. To say something about the income inequality hypothesis, we need to look into studies that use individual level data. Because in this situation, Bertil kept on having the same income in both cases. But according to the hypothesis, his health will be worse in the later situation. So if we look into, this is what we do in this book. In the very end, what we look into is that they collected the whole literature using individual level data to analyze this question. This is a graph summarizing what the literature looks like if we only take into account the studies that use individual level data. These bars, the bars represent different health outcomes, and the height of the bar represents the number of studies. So these studies show that there's evidence for the income inequality hypothesis. These show that there's some evidence, and these show that there's no evidence of the income inequality hypothesis. And actually, there's some studies showing that there's a positive relationship between income inequality and health. So, summarizing this literature using individual level data, we get much more mixed evidence for the income inequality hypothesis as compared to these aggregate level studies. Still, there's some patterns in the existing results that we can look at, we can talk about. First of all, there seems to be somewhat of a difference between subjective and objective health, with more evidence with respect to subjective health. We also see that there's some differences how we aggregate inequality, what level of inequality we look at. And I should also note that all these studies find evidence of the absolute income hypothesis, so that absolute incomes matter for our health and well-being. So I will give one exploration, just thinking, because one of the problems in these studies is of course that many of them focus on one country. And it's always problematic to generalize based on one country. And also, there's also low variation in inequality within countries. So actually, to my knowledge, there's only 3 studies that look into the relationship between income inequality and health using individual level data, but for many countries. So to my knowledge, there's 3 such studies, and actually also these show very mixed results. One show that there's negative relationship, one that there's no relationship at all, and one show that there's a positive relationship. So let me conclude. I think it's very important to understand that to understand whether there's a relationship between income inequality and health, we need individual level information. The majority of published articles analyzing this question doesn't focus on the individual level. It uses population health measures. There's ambiguous results if we look into this literature with respect to the income inequality hypothesis. And I would like to say that inequality doesn't seem to make us sick, but possibly makes us feel sicker, because there's some evidence with respect to the subjective health measures. And this brings us, if we want to continue from a research perspective to look into this, I think it's important to, of course, take into account endogeneity and possible reverse causality, but also, start thinking about whether some inequality measures to some extent captures the mechanism better, if it's the case that we actually compare ourselves to others, and that, this is what makes us, possibly makes us feel sicker. Once again, mechanism. I think these questions, why would inequality transfer or transmit into poor health, is rarely discussed in the literature. And I think this is super important, because this is how we can get insights with respect to, what to do from an economic policy perspective. I also think that what's not discussed in the literature is magnitudes. So what's the economic significance of the results? Taking one of the studies, using data for several countries, using individual level data, what we see there, if I just take that example, what they state is that going from the level of inequality in the UK to the level of inequality in Denmark, actually that translates to a very small increase in health. There's probably better ways of improving health levels in countries. We also see that absolute income seems to matter. The relationship runs both ways. We know that from a large literature, but it also means that actually redistribution matters. And I think we will talk a bit more about possible policy conclusions on this, but thinking about redistribution, what type of redistribution should we go for? Well, I think today there's a growing evidence in the economics literature on the role or the importance of early investments, and that these early investments can be universal, and they can also be targeted, but also that the universal policies tend to benefit the most disadvantaged groups the most. So having said that, I will give the word back to Cecilia.